Good day, folks. This is Dr. Arvind Kanchi. Greetings from Bangalore. I am the social media chair for the ISN education team. And this is a pre-Congress interview of speakers who will be speaking at the WCN'21. Uh, it is my pleasure to welcome Dr. Arogundade Fatiu. He is a professor of nephrology in Nigeria, pretty well known in many parts of Africa. He is also the president of the Society of Nephrology, Nigerian Society of Nephrology. There, his talk in the World Congress of Nephrology is going to be about the end-stage kidney disease burden in sub-Saharan Africa. Before we talk a bit about that, I'd like to ask Professor Arogundade, um, how did you choose nephrology? What made you get into this field?
Thank you very much, Dr. Arvind. I happen to have had my undergraduate medical training in the University of Lagos under very dynamic and competent nephrologists. Even in my undergraduate days, we saw the burden of renal failure, and we also observed that once people have end-stage kidney disease, it's like a death sentence. Fortunately, we also now saw that hemodialysis evolved in Nigeria. Thereafter, we saw patients that were offered peritoneal dialysis, and we started hearing about kidney transplantation, even though it wasn't available. I just felt it would be challenging, to be more challenging to choose a field where you'll be able to practice up-to-date medicine, 21st century medicine, and you'll be able to do what is done in every other part of the world. And you'll be able to assist our needy patients, which hitherto would have died from renal failure. So I just feel that if nephrology is a field where you can explore transplantation that wasn't available in Nigeria then it's something to go into, perhaps to be able to help more patients. And during my residency training, I happen to have worked under a very dynamic nephrologist as well, who stimulated our interest in nephrology. And we had a dynamic association, the Nigerian Association of Nephrology. Once you attend a conference, you get initiated more or less into liking nephrology as a profession. So those are the things that contributed to my choosing nephrology as my subspecialty. Thank you.
Coming to what you're going to talk about at the World Congress of Nephrology that is due next month, you are going to speak about the burden of end-stage kidney disease in sub-Saharan Africa. As I understand, the burden of diabetes is probably much less in those parts as compared to other disease processes that are causing end-stage kidney failure. For example, in the West and in India for that matter, diabetes is rising and to become the main cause of end-stage kidney failure. What's happening in sub-Saharan Africa?
Thank you very much. I want to urge all colleagues and friends from all over the world to ensure that they tune to the World Congress to be able to listen to the field lecture. However, I will say end-stage kidney disease has assumed an epidemic proportion, even in Africa. And more importantly, the causes are changing in profile. Prior to now, in the early 70s and 80s, we used to talk about chronic glomerulonephritis being the commonest cause of end-stage renal disease, followed by hypertension. And then we talk about other causes, but diabetes comes lower down. Today, I would say hypertension appears to be quite common, one of the commonest, still followed by chronic glomerulonephritis. You will agree with me that distinguishing between both, particularly if it's advanced, may be difficult. So even in defining who has hypertension, who has CGN, one may have some difficulty, particularly if it's an advanced disease. However, diabetic nephropathy that used to be just about 1% of end-stage renal disease in terms of proportion now has zoomed close to 20% in different parts of Africa. Even in places where we were never recording diabetic nephropathy in high proportions, we are now beginning to see them. And that is not far-fetched. Why? Because if you look at the community prevalence of diabetes mellitus, particularly type 2 diabetes, in the 80s and early 90s, it used to hover around 2 to 3%. In the entire country, we talk about 2.4% in Nigeria, for example. And if we're talking about community prevalence of diabetes today, we'll be talking about between 6 and 9% in different communities. If we talk about national prevalence in meta-analysis that have been done, we're talking about 5.7% of the population having that type 2 diabetes. So the prevalence of diabetes is actually rising, and that may equally be responsible for the reason why we're seeing more of diabetic nephropathy now. But we still see more of hypertension-related renal damage than diabetes. Why? Because even the proportion of hypertensives are equally increasing. We now have close to 30% of our population that have hypertension. So the proportion of patients with hypertensive nephrosclerosis or hypertension-related chronic kidney disease is equally high and is still rising. Thank you.
Professor, I am told that you are doing some research on hydrocarbons and sickle cell disease and kidney disease. How are they connected? What's your research based on?
Thank you very much. We looked at the contributions of hydrocarbons in patients with chronic glomerulonephritis. We classified them as those that have primary glomerulonephritis, secondary glomerulonephritis, and we compared them with controls. And how did we quantify their hydrocarbon exposure? We look at what they've been used to, whether they use fuel, whether they work with paints, whether they've worked in the oil industries, wherever they've worked. And we rated the hydrocarbon exposure score according to what has been used by Yakub et al. And we discovered there was significant association with hydrocarbon, particularly in those with primary GN and secondary GN. And the exposure score was far higher in them than in controls. For sickle cell nephropathy, we have looked at the contributions of sickle cell. We've done retrospective studies, and we have done quite a number of prospective studies that we looked at contribution of sickle cell to the burden of chronic kidney disease. And we discovered that the older these patients grow, the higher the chances of them developing chronic kidney disease. In particular, the evolution of the disease, just like we see in diabetic nephropathy, it evolved through classical stages. There may not be well-defined stages. We looked at sickle cell traits, and we discovered in our own series that it wasn't really significantly contributing to the burden of chronic kidney disease. But is the sickle cell trait a risk factor for kidney disease? That is left for another study. Even though that has been reported in some other parts of the globe, they've linked it with sickle cell trait with chronic kidney disease in some parts of the world. And even in sickle cell disease, we've also now discovered that the higher the number of sickle cell crises they have, the higher the chances that they may develop a nephropathy. The older they grow, the higher the chances that they may develop nephropathy. The higher the frequency of other crises, acute chest syndrome, vaso-occlusive crisis, the higher the number of crises, the higher the chances of them developing end-stage renal disease. And we see many more of them surviving till middle age, very few of them surviving into elderly age group. And in terms of nephrotic syndrome, only about 3 to 5% of them present with massive proteinuria that we could classify as nephrotic syndrome. And in terms of end-stage renal disease, at every point in time too, only about 5% of them are in end-stage renal disease. Even though when you screen adults, you may get up to 40% of them having one form of kidney damage or the other, either in terms of microscopic hematuria or proteinuria or deranged serum chemistry or reduction in glomerular filtration rate. In terms of renal replacement therapy, they survive well on renal replacement therapy, but they do not survive as good as those that are not sickle cell disease patients. And in terms of transplantation too, their 1 year and 5 year survival is significantly lower than you see in other causes of chronic kidney disease. But hope is rising. Available treatment modalities are more, and these patients are surviving into adulthood now. And what we think is that the more they survive into adulthood, the higher the chances that we're going to get more of them developing end-stage renal disease, and we have to contend with them and manage them. Thank you.
Thank you. Let's move away from nephrology for a bit and talk about life in general. How do you wind down after a tough day at the hospital? What do you do to relax?
Thank you very much. I enjoy watching films. So on getting home, of course, I tune to an interesting channel, watch drama, and then at the time of the national news, I listen to national news. And of course, when there are things happening in the international arena, I want to listen to international news as well. So you're a global person, you know what's happening all over the world. And of course, I enjoy interacting with my family, playing with them, and going on holidays. I enjoy traveling. In fact, sometimes my family will say, all this your travel, why are you going everywhere? I enjoy traveling. I enjoy reading, not necessarily nephrology, even life issues, novels, politics, and I enjoy interacting with friends, visiting friends.
Excellent, thank you. I advise all of you to come back next month, April, and visit the virtual WCN'21 that will happen online. We will be bringing most of the interviews as well as the sessions, scientific sessions during the World Congress of Nephrology to you live with tweets, with interviews, with the podcasts, with quizzes. Do join us on Twitter and Facebook and various social media, as well as register for the conference and attend the conference to learn the scientific aspects of nephrology and the advances that have been made recently. Thank you all. Thank you, Professor.
Thank you very much. Have a nice day.
Thank you.